Achy deformity, and mechanical axis planning shows there's 12 degrees of deformity. This allows us to plan the size of the open wedge We make a 4-inch incision on the lateral aspect of the leg. We dissect the vastus lateralis anteriorly, exposing the lateral aspect of the femur. I use a titanium plate as a stabilization, and I also use this as a template for choosing my osteotomy location. The position and orientation of the osteotomy is planned with a wire and then is executed with a microsagittal saw done while cooled with saline to avoid thermal necrosis. Retractors are placed to protect soft tissues. Care is taken to avoid cutting the medial cortex to keep the osteotomy stable. Laminar spreaders are then used to distract and open the osteotomy on the lateral side based on the preoperative templating. You'll notice that the open wedge corrects the valgus deformity, and this is checked in the operating room with a hip to ankle line. The titanium plate is then inserted into the optimal location to stabilize the osteotomy and provisionally fixated. Stabilization with locked titanium screws into the plate is performed. I typically use 4 bicortical screws in the proximal segment and 5 locked screws in the distal segment. This provides excellent stability. Patients are allowed to bear partial weight and move their knee without difficulty. Casting and bracing is not necessary. The open wedge osteotomy is then filled with a synthetic bone graft. This area has high healing potential, and autograft is not necessary. We're also using tranexamic acid during this surgery to minimize blood loss. A drain is placed and the incision is closed in layers. An acute correction has been accomplished, so the patient leaves the operating room with a straight leg. Hip to ankle line goes through the center of the knee. Crutches for 4 to 6 weeks lead to full healing.